let me begin by saying that you and I chatted not that long ago during amidst this COVID issue, and I think you had said something very poignant to me, which is it's taken a very devastating infection for the world to recognize, that we can be doing better for the elderly, and it's almost a siren that we should be doing better for the elderly, and probably in no other time in history has the world felt the same thing at the same time. Now, the other thing that I have, and we wrote about this and we published this back in the days of Acta Orthopedica Scandinavica. We had written a paper and I'd said the same thing that you have all echoed, which is mortality rates after hip fracture care. We haven't made a dent in them. In fact, if anything, if you look at the evidence from RCTs, like the rates seem to be going slightly up. They're not going down. And so there is this discomfort with information. And on a personal note, you very kindly show the two big studies that show no difference. And I've been feeling that kind of discomfort for probably 2 decades, in which every time millions and millions of dollars are spent to look at implant A versus implant B. And you can argue that we tried to do them well, and we have multiple, centers and all those sorts of things. But at the end of the day, you have to start getting a little bit more cynical to start thinking, maybe it doesn't really matter what implant you use, as long as you do it with a certain degree of expertise and comfort. And where do we go from there? I think that's your whole thesis. And I'm curious what others are feeling, because I have lots of thoughts and lots of questions, but let's get some other people here engaged if they don't mind, giving your own experience. I mean, how many of you have come to the same conclusion that we're hearing today presented, which is it may not be really about the implant at all. And there may be other factors, and we can have a debate about how we evaluate those factors, but let's get to that fundamental point. You can just unmute and comment. Jay.
Well, I mean, certainly there is the training and the expertise needed to pick the right implant. There's no doubt about that. And all of us have that training. But yeah, I would totally agree with you. It's the care of the whole patient. That's really what we're dealing with. And I really, really enjoyed your talk, Cecilia, and hopefully Bjarke, I hope I said that properly. Those were incredible insights. The fact that, as technicians, we pride ourselves on the technical skills that we all have, but it's much, much more than the technical skills. It's taking care of the whole person. I love that you are so open about knowing that we are not the be all and end all in terms of the overall recovery of the patient.
If I can just jump in, and I'm sure there'll be others who will have lots of thoughts. A colleague of mine, and I think known to some of you, is PJ Devereaux, who's a cardiologist, but has done a lot for perioperative research. Some years ago, he said, why do your patients wait so long to go to get hip fracture surgery? We had a debated discussion. I said, I don't think they wait long because you stop them from going to the operating room. Surgeons don't necessarily want patients to wait. He goes, no, there's this concept of medical optimization. Whatever the case may be, when they designed the study that was ultimately called HIP-ATTACK, and I won't go into the whole storyline of HIP-ATTACK, but the goal was, if you think of a hip fracture like a heart attack, can we get better outcomes by accelerating surgery? So it's really not a surgical issue. It was get patients to surgery. And I remember thinking to myself, when I looked at the data forms as we were working on together, he just said, yeah, any surgery. And I said, no. Like we spent decades looking at, A versus B versus C versus D, and you get into all kinds of details around what you think the treatment should be. And he said, we'll just call it surgery, and we'll assume the surgeons are capable and they can do it. From our internal medicine colleagues, they weren't looking at surgery as anything but the surgeon coming in and doing what he or she believes is the right thing to do. And then after that, the real action is before and after surgery. And that's gotten me thinking, broadly. I'm curious if other people have any thoughts, but these are the kind of things that I think are upon us. And if we're going to make big change in hip fracture, we'll use that as an example, I don't think it's going to come from another implant. I think that's the argument we're making. I'm curious what other people think. Paul, I see you contemplating there. I see you at the bottom there, and we'll certainly get other people involved.
Thanks. Well, hi. Excellent. Can you guys hear me okay?
We can.
Those are excellent talks. Thank you so much. I really, really enjoyed those. And I guess I hadn't really put a ton of thought into it until now, but it makes sense because through my training, which was many years ago, and even amongst my colleagues, we can't agree on how to treat a lot of fractures. For example, hip fractures. One person will use screws, one will use a DHS, one will use a gamma nail, or for different treatments. But the outcomes, you know, now I'm just realizing maybe there's no sense in having that big argument because there are different ways to treat the same thing. And we see that in hip fractures, but it kind of right across all medicine. I mean, my elevated cholesterol is the same as my sister's, but my doc put me on meds and she didn't get put on meds. It's like, what's going on? It's the same disease process, but different treatment options. So I think your point is well taken that maybe, you know, there's a variety of ways to treat something. I mean, there's ways to do it wrong, but as long as you're using one method that works in your hands, that it will work. And what really rung true for me is the big picture of the hip fracture, because I had admitted a 91-year-old with a hip fracture and she had a lot of comorbidities and, you know, pass it on to the next surgeon on call. And then I was talking to someone about that a few days ago, and then my friend said, well, what happened? How did the patient do? And I was like, I don't know. I passed it on to another surgeon and I don't know what happened. And that just goes to show that I'm only involved in the small part and not the most important part, because I don't even know what happened to the patient. So thank you, because that really rung true for me.
Well, there you go. Thank you very much for that. Yes, Cecilia, please.
Yeah, because I think this is so very deep within us, those surgical details. And some of you have heard me speaking about this before. And when I have a presentation like this, there's always someone in the audience raising their hand saying, yeah, well, but which is best, do you think, bipolar or unipolar? After a presentation like this. And I'm like, please listening, it doesn't matter, because it's always dangerous to say that we have reached perfection and nothing will be better what we're doing now. Of course, in 30 years, someone will laugh at us, but I think getting rid of the Austin Moore, getting rid of osteosynthesis for those displaced in the very old ones, there we gained some major differences for the palpable for the patients. But dwelling into those details, A versus B, will take our focus from what has to be done. And I don't think that we as surgeons, we should not see the patients each and every month for 6 months, but we have to know what's happening to them. And as Paul said, maybe we know what's happening from one day to another, but we have to understand where are the bottlenecks of the care pathway and how can our department see to that the investment we made when doing surgery, investment of our time and investment of the patient's health and life, we have to protect that investment for her sake.
Well, clearly you've put some thought into this, Cecilia, I imagine. So where do you both feel, you or Dr. Viber, where do you feel the opportunity for targets are? I mean, is it in the rehabilitation phase that we think we're going to get the maximum opportunity? And I guess this is going to be informed some degree by observational data sets where you look at factors that are potentially associated with outcome, and then you look, can we modify those factors, right? Are they modifiable? But you must have put some thought into this. Yes, Bjarke.
Yeah, so we've just in Denmark made a national program in improving hip fracture care. Mm-hmm. And at my department, we said, okay, we need to do the pre-op care better. We need to do the post-op care better. And we had everyone in emergency department, theater, the radiology, the ward, the physiotherapist, the geriatricians, and we all sat down, made a plan what to do better, optimization before, faster, no surgical delay, and so on and so on. And when everybody was agreement what the plan was, we hit it off. And within this year, when we've done all these changes, we actually lowered the mortality from the 30-day mortality from 10% to 6%. And it was not just one thing. And I think this is the most important thing. It's not one implant, it's not just one geriatrician, it's all the way around. So we need to optimize all places in order to get these improvements. And this is both pre-op. I don't think we can gain much from the pre-op, but we do tend to lose the patient that's fallen due to pneumonia, and we don't see it. And after surgery, they get worse and they die. We can see these small improvements, but afterwards, the mobilization, the rehab, talking to the municipality as we do in Denmark, getting better and faster rehab. I think that's really the point.
That's interesting because, when people run regressions and they do the, sort of the standard approaches, they're always looking for what is the factor rather than it's small changes in a number of factors, anywhere from diet and nutrition on one extreme all the way through the end, right? And we often tend to minimize things that aren't the big win. Tell me a little bit, if I could, and I'm curious because we have spent a lot of time thinking about, well, what outcomes matter in hip fractures? You've put some thought into that. So you are suggesting, I think, from your discussion that maybe some of our traditional outcomes aren't necessarily the ones that truly matter. What kind of outcomes should we be measuring when we're looking at outcomes following? And we'll use hip fractures as an example, but it could be any real outcome measure. What's the approach we're using to be determining what outcomes are valuable?
I think, to be a bit provocative, I don't think that mortality is the most important thing, because if we dare to speak with these old individuals about dying, it's not what they fear most. Many are very rational about this, but they fear to lose life as independent human beings. And I think it's really important to try to understand what's important for the particular person in front of you and try to address his or her worries about doing what's important. And we think that an 80-year-old is more or less the same, regardless of the person. But we have to find out what's important for that particular person.
Oh, absolutely. Well, let me ask you this. When we say about we don't know what the optimal outcome is, the one thing that everyone says, okay, function. We have tried, and I think you've also said the same point, is trying to collect function of patients is really, really hard and often fraught with all kinds of problems with collecting the data and then making assumptions on so much missing data, et cetera. How do we get to this? How do we get to what would be easy enough to do, yet and meaningful without, when being valid? Because that's the biggest challenge we found, that we've almost had the psychology in some of our trials that we may forego functional data collection because just you're getting 40%, 50%, and half of the measures we're using, it seems to be challenging for patients to complete, and we're not even sure what it means at the end.
So if you look at like function, so
yeah, function.
We can, as it is now, you can do the activators. You can get these accelerators, and you can measure it and can actually measure it. But I'm not sure that's what the patient think is the most relevant. As I come from a hospital where the only thing we talk about is patient satisfaction.
Yeah.
If the patient's not satisfied, then it's not good enough. And then it's of course also about what are their expectations and so on. But so in all, do we have any questionnaires right now that's actually going into the patient's view? And all these questionnaires are made from doctors to doctors and not right. From patients to doctors. And I really think we need to go into this looking at ways that the patients can actually answer some of these questions for us, because now we're actually looking at what is the patient's view and when are they satisfied.
I think, Miriam, you posed a really interesting comment. I wonder if you might unmute and just share that with the group rather than me try to paraphrase what you're trying to get out to the group. I think it'll be much more insightful if you tell us.
Thank you. Thank you for the presentation. And you just talked a lot about trauma. And I was wondering the effect of trauma and the expectations after surgery. How is it set? Is there any evidence for how to, I don't know the word anymore, but how are you dealing with expectations? And to what extent does it influence the outcomes? Is there any literature about, or that was the question? Thank you.
Sure. I'll throw a comment in, but I know there's going to be, I'm sure Paul or Jay or others will have it. I suspect even Yad, you might have a thought or two on this issue of patient expectations in general. But the one thing that I used to always hear and say about trauma and was always told to me when I was in training was, you know, trauma is unique in that patients come in well and they have a dramatic event that changes and it's bad. And they think often if their expectations are such that they think they'll never recover or they'll lose their leg, something that may be totally irrational based on like an ankle fracture. The simple perception that the surgeon has in interacting with them by saying, quote, this is a fairly simple fracture, I think you'll get full recovery, is a very different mindset for the patient than, wow, this is the worst fracture I've ever seen, I hope you can walk again. And when they walk again, they're just elated. They're elated, right, that they could walk again. And those that had a relatively simple fracture that you had promised them great things are limping and I'm very unhappy. I mean, you can see that sort of psychology. We had even toyed during my residency of doing a randomized trial, which was deemed unethical, sadly. But I think it would be very important to actually have two different ways in which you do informed consent with the patient, and one which you call it the catastrophic outcome, which is, this is a very complicated fracture. We'll do our best, but we're not promising that you'll be, jogging again. And the other one saying this is a fairly straightforward fracture. Our experience is good, and we would see that impact. But it's very hard to get to that point. There have been tools developed. One is called the somatic preoccupation tool that's been developed at McMaster, where they try to get to general patient psychology. Are you optimistic in general in life? Or are you pessimistic? If you're optimistic in general, you might have a slightly better opportunity for an outcome. If you're generally pessimistic, and I'm using that, I'm paraphrasing it, it's much more complicated than that. The outcomes may be different. But I am very curious for those who have thoughts on that one specific issue about patient expectation. I think it's a very important point to raise when we're thinking about designing research, and more importantly, trying to figure out whether something works or doesn't.
I think that sort of making it catastrophic or not catastrophic is parallel to what we do with arthroplasty, specifically total knee arthroplasty, because we want to wait till the patient is catastrophic, like in their pain and dysfunction, before we do anything, because then we know we have a good chance of making them better. And we know even if they're still not feeling, even if they're not 100% after, as long as they're better than how bad they were before. When I do second opinions on painful total knee replacements, I always try and go back to, well, what were you like before you replaced your knee? And if you weren't that bad, then that might be why you're still not happy. And so I think that's sort of parallel to what you're saying, where the mindset is to tell someone their fracture is so catastrophic that an outcome anything less than catastrophe makes them happy. It's sort of the same mindset we use with elective surgeries.
Right, but I would think it would make sense. And we've started a little bit, I must say, Miriam, that we've started a little bit about building in these operatives, sort of the preoperative questionnaires, although they're somewhat tedious, but we've been building them in to try to get a sense, and it's been done earlier, even with trauma, in programs where they try to look at the personality profile of the patient to help guide whether or not outcomes are going to be, more positive or negative. To a lesser extent, we've been doing it for decades with using some sort of, a disability status or workman's compensation has been another surrogate for these sorts of things. Rightfully or wrongly, but that's always been part of, I think, that debate. Oh, yes, Cecilia.
Yeah, I think regarding the orthogeriatric patients, we don't deal with expectations at all. I think it's a problem that we don't have the fantasy to think about whatever they would like from the future. And another interesting case I had, that was a quite fit 75-year-old who had a total hip due to a displaced femoral neck fracture. And she came to my clinic and she was very disappointed with her hip. And everything was fine. And I couldn't see anything wrong. And she moved quite freely. And then she said, my friends, they have also artificial hip, but they are much better than me. Okay, but they maybe had osteoarthritis. Yeah, she said, but what's the difference? I would like to be as good as they. And I usually can have a conversation with the patients and we find each other in that conversation. But she was so dissatisfied with her hip. And she couldn't understand that I talked to her, this was a trauma for you. You didn't choose to have a total hip. Your friends, they looked forward to have the surgery. She thought I was only glossing over that her hip was a failure. So her expectation was sky high. And I think it's really very difficult to meet the patient's expectations, but at least we have to ask.
I think you're right. I don't know if I saw Olaf, I see Sebastian, I think Yad. I don't know, one of you three wants to speak. So all of you. Yeah. Okay, so you know what? I'll go Olaf and then we'll go Yad. Olaf, go ahead.
So I work with the Swedish Fracture Register, and we have that question about expectation. Do you think you will recover, or do you think you will not recover? And it really makes a difference in the outcome after 1 year. The people who have an ankle fracture and think they will recover, they do better. And the people who don't think they will recover as well, they have worse outcome measures.
So Olaf, let me ask you this. When you say, so broadly, that makes sense, because I think everyone here would say, okay, that would make intuitive sense. Is like, how big a difference is that? Like when you've looked at it in the register, how big an impact does that have? Like, does it overshine other things that we think are important that we're focusing on, and we're not maybe focusing on patient expectations and informed consent and all the other things? Because I think sometimes you just gloss by it. Cecilia says it's not even brought up in most of fracture patients, right?
We covered it in one of our annual reports. I don't have the figures in mind yet, but it made a difference between the groups. And I think that's for all trauma. Well, we're discussing more hip fractures today, but also expectations for that would matter. And I know that the Danish groups, they publish a lot about orthogeriatrics, and it makes a big difference for mortality, much bigger difference than what implant we use. So I think there are other things to look at than implants, as you were discussing before. So what we do with the patients afterwards. And I was wondering, Bjarke, if you look at, if you work with pharmacists in Denmark to look at the different drugs they take, the polypharmacy that makes the patients fall over again and get a second fracture.
Yeah, we do have pharmacists at the department, but what they use from is like only checking if we do the same as the practitioners does. So we don't use them in that way. The geriatrician look at it, but they just look at it and then say, why did they fall? And then they see them if they feel like it. So we don't do that enough.
No, very good. Thank you. Ya, did you have a comment?
Yeah, it's just a comment. Thank you so much for hosting this and putting this together. It's been wonderful. I am not a surgeon, so it's been very refreshing to hear everyone's viewpoint on this. But I think everyone keeps saying the same thing, is that, and the way I've viewed the trials is that we look at surgical outcomes, we look at the technique that was used, and we look at patient-reported outcomes, and we look at rehab. But that psychological component about speaking to the patient, I think, is oftentimes missing. And forgive me if I am speaking out of turn on that, but I don't think sometimes giving a questionnaire on how are you feeling and how your expectations are is enough, because that is something that we have to communicate to each other. So I think if we started, and I say we as collectively, but you guys started bringing in psychologists or psychotherapists as as maybe when patients are sent home, and that's part of the actual study. That may be something that's very enlightening and informative to these types of trials.
Yeah, I think you're right. I think the challenge we have, and absolutely, Sebastian, you'll be right off to this. You're next, my friend. So, the challenge here is that when you're trying, it's two-stage. Like so, qualitative research is, as you know, always, at least in orthopedics, has been looked at. Oh, what's this? It's over there. We do data. We look at data, and whatever data you look at is more important than qualitative. As you learn, as you mature in research, you realize the qualitative data sets are rich, like really rich, and that's where real insight comes from. Part of the reason we're having this discussion over a webinar, there's no series of question and answers that we could manage that will get us to a deep dive, at least on a particular topic, the way we're trying to do. So I agree with you. I just wish we have to revolutionize the way we think, or at least evolution has to happen with the way we conduct research in this area. And it's not enough to say multidisciplinary. It's not enough to use catchphrases and almost memes for how we do things. We think we have to really think deeply with thoughtful people about the changes we have to make. Sebastian, did you want to say something? Please share.
Thank you, and thank you for the presentations. I was going to say, like you just said, Mohit, about the qualitative studies. Maybe that could be a way to guide us towards reaching somewhat what the patients expect. We're performing a study. I'm one of Cecilia Rogmark's PhD students, and we're performing a study in young hip fracture patients under the age of 60. And most of those patients, after the recovery, they get interviewed, and most of them are quite concerned. They don't do very well. So some do, but most of them don't. And I think that could be a way to know what the patients expect or what the patients think is important.
No, absolutely. I think we don't use that tool enough. It's a very important research tool, and I don't think we do enough of it. So I fully agree. I'm going to ask Dr. Morrow, if I can, to put him a little bit more in the spotlight, to think about some issues. He has someone I've known for some time who's thought a lot about non-operative care, more of a holistic approach to patient care. And I wonder, Jay, if you might share a little bit about some of the insights you've had, whether you want to speak to specific patient encounters, but more importantly, your general thoughts about how important it is to, for the whole mind-body experience in managing patients.
Yeah, thanks for the spotlight. Well, you have some incredibly accomplished researchers here, and it's incredible the work that's done. And it's so wonderful to see that it's not just about the quantitative, but as you say, it's the qualitative, and that's fantastic. And I'm, part of this comes to me from having been a meditator for almost 30 years. So, you think about having been in practice for 20 years and you notice patterns. And I kind of have this cubbyhole hypothesis of life for people that you see. It's like you meet someone at a party, and I meet Cecilia at a party. I know her name, but I don't really know her, and it'd be great to get to know her. Who is she? What does she do? What's her family like, etc. And I think that's kind of what we're slowly evolving to in terms of patient care, right? So this sort of cubbyhole hypothesis, I wrote a few points down, sorry. So you're talking about the social determinants of health, the person's environment, their friends and family, what are their relationships like, hobbies, what are their outlooks? You mentioned pessimism versus optimism, psychological state, their life circumstances. And then there's the stuff that we as doctors do to patients, right? Are they on polypharmacy or not? How is that affecting them? And then my big interest is in functional medicine, which is nutrition and vitamins and supplements, and what are their hormone levels like? Because we know stress increases cortisol, and we know cortisol has incredible effects on the body. let alone bone healing. So, you know, how do you incorporate all of that into a busy fracture clinic or in the emergency room when you're consenting someone for an operation? So that's the hard part. It takes a bit of time. And I think the other part of it is, what is the surgeon's outlook? You know, I think, is it Norman Deutsch? He wrote that book, The Brain That Changes Itself. It's all about neuroplasticity. And he talks about mirror neurons. So what about the state of the surgeon? We all know there are surgeons that are super comfortable with everything they do. And we all know surgeons that are very stressed with any perturbation of life, let's say. So you have this super stressed surgeon who has to do this hip fracture. And with mirror neurons, I'm speculating, I don't say I know anything about this, but does that surgeon's stress get transferred to the patient? I don't know. I think it's a good question to ask. So, you know, do you have a peaceful, confident, calm surgeon who is going to help this person, guide this person, and get to know this person? I don't know what more to say.
Oh, no, it's
That's
good,
a lot of points.
You're right, but the point is, right, everything that I'm hearing, whether it's, you know, Yad talking about how we're not connecting enough, Sebastian saying we need to do more qualitative work, you know, Bjarke saying that the current standards aren't where they should be, and you saying, well, no, maybe the surgeon, you know, it's more of this existential perception that, you know, from your mind goes to your hand and from your hand goes to the patient, and if you're not well, you're almost willing the patient not to be well, you know, in a you know, metaphorical way. But none of this is captured in our data. Like, we don't capture this. Like, we don't, hip fracture, the next 50 papers, you know, you watch, we can do another review, and we can meet again in another month, and we'll have, you know, Bjarke will have another 10 papers. Hopefully, now I'm not going to do any more. I promise you, I'm going to be very careful now. I've learned. But the point is, we're just plodding along, and millions of dollars are being spent. Why? Because it's really easy to write an A+B study or A versus B study and get, sadly, multiple millions of dollars to do research. Now, I'm not saying it's easy, but it's, you know, contextually it's easy. If you look at what happened in COVID across the world has had hundreds of millions of dollars put in for treatment. Anything and everything goes, right? There have been probably many other bigger issues that have just been completely left to the side, because the focus universally became on find anything that we can use to potentially treat, right? The kitchen sink mentality and all kinds of money. The challenge is sometimes the more important, complex studies that are hard to do don't get funded, and they don't get done because we all kind of just, you know, research is stuff you have to make, you know, you got to survive. So you got to figure out what to do and where to go. But I do think we have to be sitting on this type of discussion is critically important. Cecilia, I'm sure you have lots to say on this, but
yeah,
we've got to find ways.
In line with what you are saying, it's the problem is that implementation is not as good as research, and I think we have to do some research on implementation as well, because we know so many things that we should do, and maybe just starting to do them and thinking a little less of how to measure the outcome, but just starting to actually do what's there evidence for, I think is important.
But that gets back to, now I'm going to push it a little bit to the issue of the guideline. So we all know that there is, well, I don't know how many guidelines, as many guidelines as you can guess there are that many guidelines. And then there's a few more always in development. Not to say it's good or bad, but that's where we are. And every guideline seems to be slightly different. And every guideline group tends to think their guideline is the guideline you should follow. So we have, again, this tough situation. In the argument, and maybe I'll ask you this, how important do you believe the guidelines should be? Is it an issue of reinventing guidelines, or is it more an issue of making sure people are using them? And as you said, implementation. I think there's a bit of both here, because I don't think most guidelines cover some of the issues that we're talking about in a way that I think would help really understand, and potentially through a series of small differences, make it, like that to me has been the big insight for me. One of the big insights, which is I myself tend to focus on what's the big target. right? Because you're selling a target to somebody else to say, of all the things you can do, this is where you're going to go. And if you fund us, we'll figure it out for you. That's been the story of the standard ABCs of grant writing. I can't imagine a grant saying, it's a bit of everything. We have 1,000 things we have to do, and we're going to try to figure it out. They're going to say, come back to us when you've figured it out, right? That's the cycle. So it's a rewiring of what we have to do, at least in my own mind. And I'm talking out loud because I'm going through this epiphany with you today. Anyone else have a thought? Or yes, please. Just unmute. Yeah, that's great, Nicola.
Hello.
Great. Hi,
Hello.
Nicola.
Hello. Thank you for the wonderful presentations. I was wondering if telehealth, in the light of COVID crisis, doesn't offer more opportunity to gather quality data, and if machine learning would not be possible to be used after to analyze this data to get a better sense of what variables we should look for. Because I think that it's very difficult combining subjective measures and objective measures to get a very clear view, at least what questions we should ask. And I think that variable selection offers a big opportunity in this.
That's
from machine learning.
So thank you for introducing two more important topics that could easily be an hour each, but let's try to get them in 2.5 minutes each. So anyone have a thought on telehealth? I'm sure lots of people have thoughts on telehealth. I have a few thoughts on machine learning, so I'll hold off. Who's been using telehealth? I guess maybe that's the first question. And based on that, is there, how do you see it being used potentially as a research tool? I think also to collect information that you might not otherwise be able to collect, or probably collecting more information, I presume, right, in terms of compliance.
I think that telehealth can be useful both for collecting data, but also for improving the outcome or the way the patients see the outcome. Because just speaking with the nurse time to time will make them feel better, will make them feel better taken care of, and probably just speaking to them will improve the outcome in their view.
So what you're saying is that the standard aliquot of 6 weeks, 3 months, 6 months, etc., having intermittent follow-up and contact throughout that period of time creates a sense of connection. Oh, I see. Yeah, that's actually interesting.
And also offer an opportunity to collect more data.
Of course, yeah. The issue of machine learning, has anyone here been delving into what we'll call big data, right? So, when you look at the historical stuff that we're doing, it's trials. Trials is relatively small. 1,000 patients is nothing in terms of big data sets, but, the amalgamation of data in a way that you can actually run algorithms and, bigger insights is, I think, where we're seeing lots of interest. As an example, I suspect you may be aware in the COVID era that we've seen lots and lots of rapid tools, right? And a couple of groups that were very prominent groups, had papers in New England and Lancet, not in a good way, but retracted because they were purporting that they were, getting all this data very quickly. So the promise, I think, of machine learning is also the peril, is you've got to find ways in which we're collecting data to do it in a way that is sound, is reproducible, and that's the challenge, right? Everyone says, I presume that you must have some work in the area of machine learning, but I can tell you, a lot of people are throwing it around like they used to throw around the word EBM. Everyone's doing EBM, but when you dig deeper, you realize very few people are doing EBM the way you would think it should be done thoughtfully. I think machine learning has become the catchphrase for many, many groups who are sadly quite uninformed about it. And so we need I think we need real science and scientists to come together with, thought leaders to put this stuff together. But I personally think it's a huge opportunity for us. I'll stop here, but anyone else have any thoughts on big data as the future? Yes, Bjarke.
We're also trying to do a study looking into machine learning or AI and so on. And the main thing is to get big data, because as now, when we look at our registers, when we look at all the variables, we don't actually know much about the patients. And if we want to know more, we need to get all the information out from the healthcare charts and so on. So our project is just using the AI to get these information out from the patient chart and getting into our registers. And that's one way of getting big data. And I think it's the right way. And you can also use it for diagnosis. You know, I think the AI will probably get more correct hits on reading a radiologist radiograph on hip fractures than two surgeons. So there are many ways we can use it, but there are also, as you say, right now it's a catchphrase, and you get a lot of money for studies that actually don't affect the patient care.
Oh no, you're absolutely right. And I think the one thing that I would say is, you know, when talking to individuals whose career aspirations and work is related to AI, machine learning, or deep learning, their biggest issue is it's data. We don't actually have good access to data. So everyone says we're going to take, you know, hospital, you know, online data sets from here, and they goes, but the problem is they're such unstructured quote data, you can't do anything with it. And so, you know, on a small note, you know, I'll just speak to what we've been trying to do at Ortho Evidence very briefly, but you know, you've got 7,000 randomized trials. So we've been using that structured data set to extract, which is about 30 million data points, and also look at the power is when you can bring other data sets in, like for example, user behavior, right? So if you know, based on who's reading what, that's where you get the intelligence side of it, right? Obviously everything's protected and blinded, but it's the issue of, one thing is collecting good data. The other thing is how does the healthcare network, how does the ecosystem of healthcare actually use that information? Very much like we see it's being used in many other areas, where they're looking at those two, that interplay. And I think that's what's going to help us. Now, we haven't figured it out. We're not even close. But the point is, that is where I feel the future lies, but it's really hard. Cecilia?
Yeah. Working with register data, national register, that used to be big data. It's not big data anymore, but we still have the same problem, that we have to understand the data and its limitations. And the problem I see today is that statisticians and IT people will kidnap our data and do a lot of analysis until they find something interesting. Mm-hmm. And we have to be there as clinicians, as surgeons, in order to make them understand. And we can get back to comparing implants. And in all register studies, you will find that total hip would be associated with lower mortality than hemiarthroplasties, regardless of matching whatever method we use. And those subtle differences between two individuals we see as orthopedic surgeons, choosing total hip to one, hemi to the other, will not be captured in our register, because that's the clinical eye. And if someone thought I said something about orthopedic surgeons being ignorant or whatever, it's not true, because we are skillful and we have experience, but we have to use it in a much broader field.
Absolutely. We are at exactly roughly an hour. I want to respect everyone's time. More than enough insight has been gained on this session, so I can't thank you all enough for participating. I can't thank our speakers, you know, Bjarke, Cecilia, wonderful. But again, the richness of this hasn't been just the speakers, as you've gathered. It's been all of us engaging in a meaningful discussion. So thank you all for taking time to help us understand why our outcomes aren't what they should be, but in fact, putting us on the pathway to say we can actually move forward. I'll give you the last word, Cecilia.
I thank you all. It was very good having you with us in this discussion. And what I've learned from this session is that I think we should listen more to our patients. Some have too low expectation, others have too high expectations. We should listen and not preaching.
On that note, thank you all for another wonderful OE Insights session. There's lots more coming, so if you feel free to send me a note and we'll join in for other ones as well. But thank you again. Have a great evening. Have a great day.